Good morning. Can you hear me? Can you hear me?
Yes, sir.
Okay. So today we will discuss Cushing syndrome. Okay. It's a very important topic as far as your theory paper is concerned. Right? You may not get a case, but it is important to know about Cushing syndrome because it is one of the cause of the secondary causes of hypertension. Okay. So Cushing is named after the name of a person who is a neurosurgeon. His name is Harvey Cushing. He described patients with pituitary adenomas, which are known as basophilic adenomas, in 1932. 7 cases of pituitary adenomas where the Harvey Cushing described where he treated these patients, and ultimately they recovered. So the disease was named after him, and that is known as Cushing syndrome. So what is the Cushing syndrome? Before we go to Cushing syndrome, let's first take out of what the patients with Cushing syndrome usually presents with. They can be of any age group. However, it's common in the middle age or the younger age group. They come to you usually, they'll come to you with weight gained, okay? Like in this man here, will come with fever, red tender areas on his thigh consistent with erysipelas. So that means this patient came with some infection, okay? So what does it mean? It means that patients with Cushing syndromes are prone to have infections. So this patient presented with erysipelas, which is the streptococcal infections of his right leg. So what does his medical history says? That he has fatigue, easy bruising, and weight gain. So these are important. His family history is negative for diabetes mellitus and hypertension. Physical examination shows central obesity. BMI is 32. The normal BMI is usually below 25. So the waist circumference is 115. Usually normal is up to 90. The blood pressure is high, 160/104. He has moon face appearance, a dorsal fat in the neck, and abdominal purple stripe. Okay, these all one slide here will describe all the physical characteristics that a patient with Cushing syndromes will present to us. Okay, so what is a cortisol? You know that cortisol is a hormone which is secreted by the adrenal gland, adrenal medulla. What does cortisol does is that it is one of the counter-regulatory hormones for insulin. That means it counter the insulin actions. So you know that insulin reduces blood sugar. So cortisol tries to increases the blood sugar. So that means insulin and cortisol are, one will work to reduce the blood sugar, another one will increase the blood sugar, and that is why it's known as a counter-regulatory hormones. So it maintains, that means together with insulin, they maintain the normal glucose metabolism. At the same time, cortisol maintains the blood pressure through the adrenal axis. It controls the immune functions and inflammatory response. So that is why if a patient with Cushing syndromes, they will blunt the immune functions, and ultimately when there's too much steroids, we used to say that when they have too much steroids, and what happened, the immune function decreases, and these patients will have recurrent infections. And the cortisol also help the body respond to stress. That is why it's known as stress hormones. So that is why we say that when a patient is under stress, there is secretions of the counter-regulatory hormones like cortisol, epinephrine, norepinephrine, growth hormones. These are all stress hormones. So the most important stress hormones that we have are usually the cortisol and epinephrine and norepinephrine. So they will have what is known as the flight or fight mechanisms. Okay. So before we proceed further, let us look into the hypothalamic pituitary adrenal axis. So here we have the hypothalamus, here we have the pituitary glands, and here we have the adrenal glands. So what controls the cortisol secretions from the adrenals is the hypothalamus. Hypothalamus will secrete what is known as the corticotrophin releasing hormone. Corticotrophin is the other name given to adrenocorticotrophic hormone. So corticotrophin releasing hormone or ACTH releasing hormones is secreted by the hypothalamus. This will stimulate the anterior pituitary gland to secrete the ACTH, and ACTH will stimulate the adrenal medulla to secrete the cortisol. So as we already described, that the hormones secretions from the body depends on the feedback mechanisms. So here we say that there is a plus sign stimulates. Here, if you have too much cortisol, there will be negative feedback towards the hypothalamus. It depends on that. So the normal mechanism is that the hypothalamus will secrete the corticotrophin releasing hormones, will stimulate the anterior pituitary gland to secrete ACTH, and this ACTH will stimulate the adrenal cortex to secrete cortisol. So what is Cushing syndrome then? So whenever we use the word syndrome, it means that it is a constellation of signs and symptoms. So it is not a single entity. So when you talk about syndrome, this one is definitely a collection of signs and symptoms due to any reasons. Okay, so in Cushing syndrome, it is a collection of signs and symptoms due to prolonged exposure to an elevated level of glucocorticoids. Okay, so when you talk of glucocorticoids, we divided the excess glucocorticoids in the body into two forms. One is the endogenous, another one is exogenous. When endogenous means that it is being secreted from the body, that means there is some abnormal function somewhere in the body that increases the glucocorticoid overproductions, or when you have too much cortisol or glucocorticoids which is being produced from the body, that is known as hypercortisolism. Exogenous is the most common cause. Remember that when it comes to the postgraduate exam, the most common cause of Cushing syndrome is exogenous glucocorticoids therapy. Okay, that means this is being used because of some reason, can be because of overdose of steroids, or because of prolonged use, or because of excessive use, or because the use without being monitored by the personal healthcare personnel. So these are known as exogenous, mostly coming with therapeutic administration of synthetic steroids. But at the same time, though it is therapeutic, not all patients who are on steroids will develop Cushing syndromes because they are being monitored on the dose and durations. Okay. So, however, if in the postgraduate entrance exam the question comes, the most common cause of Cushing syndrome is exogenous corticosteroid intake or therapy. So let's go through some definitions which is important. When you talk of when we say Cushing syndromes, mean there is an increase steroids, which is glucocorticoids or cortisol, due to any cause. If you say Cushing syndrome, then that means it is a cortisol secretions which can be from any cause. It can be a hypothalamic cause, it can be an pituitary cause, or it can be an adrenal cause, or it can be an ectopic causes. So irrespective of the cause, if the steroid secretions is more in the body, that is known as Cushing syndrome. This will differentiate from the next one, which is known as the Cushing's disease. If a patient of Cushing syndromes presented to us, and if you label the patient that the cause of Cushing syndrome is because of Cushing's disease, mean that cortisol secretion is due to a pituitary disease. Okay, it is due to a pituitary disease. If the cortisol secretions is due to a disease of the pituitary, that Cushing syndrome is known as Cushing's disease. Pseudo-Cushing syndrome. So sometimes you can have increased cortisol secretion in several disorders, which I'm going to tell you. These are known as pseudo-Cushings. Because why they are known as pseudo-Cushings mean is that you estimate the cortisol secretion at that time. You will find that these patients have increased cortisol, but they do not necessarily have the signs and symptoms of Cushing syndrome because the hypercortisolism in this patient may be short term. Okay. Cyclic Cushing. Cyclic Cushing means cyclic Cushing means that usually it is a period of cortical excess because of some reason, alternating with a period of normal cortisol secretion. So these are known as cyclic Cushing's. However, the most important thing is that you have to know what is Cushing syndrome and what is Cushing's disease. And of course, Pseudo-Cushing syndromes, we will tell you what are the causes which can have Pseudo-Cushing's. So Pseudo-Cushing syndromes, we divide Pseudo-Cushing syndrome into two categories. One is physiological hypercortisolism that may have some clinical features of Cushing syndromes. Number one is pregnancy. Okay, a patient with pregnancy, it is a stressful state, so you can have hypercortisolism. And a patient with pregnancy, they will look hefty, weight gain. All these will have some clinical features of Cushing syndrome, but not necessary. Okay, because pregnancy usually the blood pressure is normal, or instead normally it is on the lower side. So not all signs and symptoms of Cushing's will be there. So usually they are known as pseudo-Cushing's for that reason. So weight gain as such, whether with or without increased cortisol, pregnancy, you will have weight gain. Patients with severe obesity, okay, especially those with visceral obesity or polycystic ovarian disease, they will have pseudo-Cushing's, physiological hypercortisolism. Patient with psychological stress, okay, especially patients with severe major depressive disorders or melancholic symptoms, poorly controlled diabetes mellitus, chronic alcoholism, physical stress, illness, hospitalization, surgery, or pain. For any reasons, you will have increased cortisol secretion. And a patient of obesity having obstructive sleep apnea will also have increased cortisol secretion, because obstructive sleep apnea also is a stressful state for any patients to have these problems. Okay. Physiological hypercortisolism that are unlikely to have clinical features of Cushing syndromes. Okay, intense chronic exercise. See, patients with even with pathological Cushing syndromes, if they are in athlete or in patients who are used to chronic exercise or heavy exercise, may not have the weight gain which is proportional to the cortisol. So that means you will do the estimations of the cortisol, you will find that it is very high. You expect that the patients will have all the symptoms and signs of hypercortisolism or Cushing syndrome, but in a patient who is an athlete or who are used to intense exercise, you may not see weight gain, which is suggestive of Cushing syndrome. In a patients with hypothalamic amenorrhea, high corticosteroid binding globulin, for any reason, if you have high corticosteroid binding globulin, the increased cortisol level, but not the urinary free cortisol. Okay, so do this one, you just know the causes: intense exercise, hypothalamic amenorrhea, high corticosteroid binding globulin, glucocorticoid resistant cases. Pseudo-Cushing's, I'm telling you here, is for your knowledge about Pseudo-Cushing's. As far as your exam is concerned, they will ask you, define Cushing syndrome. What are the causes of Cushing syndrome? How will you manage a case of Cushing syndrome? Okay, so the Cushing syndrome, Pseudo-Cushing syndromes may come usually maybe one or two questions in the viva or in your long case when you get cases of obesity, or maybe get a pregnancy, a patient of pregnancy, or a patient with secondary hypertension. What are the causes of secondary hypertension? Maybe you have to talk about Cushing syndromes, pseudo-Cushing's, etc. So this is a very important slide for you. You have to know this. Cushing syndrome, what are the causes? We divide Cushing syndrome into two causes. Okay, one is ACTH dependent. Okay, ACTH dependent mean that this is related to a disease which is in the brain or ectopic. Okay, ectopic secretions of ACTH. That means ACTH dependent mean ACTH is increased. So one is Cushing's disease. You know, when we talk of Cushing's disease, you know that it is a disease of the pituitary. When you have a disease of the pituitary causing increased ACTH secretion, then that is one of the cause of Cushing syndrome. The other is ectopic ACTH syndrome. Ectopic ACTH syndrome, that means for some reason, for example, the most common cause of ectopic ACTH syndrome is the lung carcinoma. If you have lung CA, then you can have an increased ACTH from the tumor, and that is known as ectopic secretion. So you have ACTH is high. Or at times you can again have ectopic corticotrophin releasing hormone. Corticotrophin releasing hormone is normally secreted by the hypothalamus. But at times in some tumor, the most and the only usually mentioned about the ectopic corticotrophin releasing hormone is usually again a tumor of the lung. It is a very, very rare condition. So in these conditions, you'll have ACTH to be high, and that is why it's known as ACTH dependent Cushing syndrome. Now we go to the next, ACTH independent Cushing syndrome. That means in this case, the high cortisol level is not because of increased ACTH. So that means forget about hypothalamus, forget about ectopic, forget about pituitary disease here. It is definitely a disease which comes from a condition, from areas which are not dependent on ACTH anymore. So when you have about ACTH independent, I mean, I don't depend on ACTH to secrete cortisol. That means it is you know that cortisol is being secreted by the adrenal gland. So that means a disease of the adrenal gland itself, irrespective whether I have ACTH or you don't have ACTH, the adrenal tumor will secrete cortisol. So that is why it's known as ACTH independent causes. So adrenal adenoma, adrenal carcinoma, or micronodular hyperplasia or macronodular hyperplasia of the adrenal glands. So when you talk of adrenal adenoma, mean it is a benign tumor of the adrenal gland. Adrenal carcinoma is usually the malignant conditions of the adrenal gland. When you talk of hyperplasia, is divided into micronodular or macronodular hyperplasia. The difference between these two, that means the hyperplasia and the tumorous conditions, is that usually tumorous condition is unilateral while hyperplasia is bilateral. I hope you got the point. And of course, the causes of Cushing syndrome are Pseudo-Cushing, which is pseudo, as the name suggests, we have described already. Other than these, there are many other causes which I have already mentioned to you. They mimic Cushing syndrome. Okay, so you'll have to take into considerations also, however, Pseudo-Cushing syndrome. What are the causes of ectopic ACTH secretions? The majority of the ectopic ACTH secretions come from the lungs, which is the most common cause is the small cell carcinoma of the lung. What are the other endocrine tumors which can secrete ACTH? Thymic carcinoma, islet cell tumors, medullary carcinoma of the thyroid, bronchial carcinoids. These also can produce ectopic secretions of ACTH. It's quite high. Pheochromocytoma, about 5% of the cases. Ovarian tumors, about 2% of the cases can secrete ACTH. So let's talk here about Cushing syndromes, okay? So Cushing syndromes can be because of exogenous, that means iatrogenic, because of some therapy, or endogenous. Exogenous means prolonged administration of what? Glucocorticoids, for example, prednisolone, hydrocortisone, etc., which we use, or a person who is getting ACTH directly. Endogenous again is divided into ACTH dependent causes. We have, I told you that ACTH secretion depend on hypothalamus or pituitary. So it can be an hypothalamic lesions or a pituitary lesions, or ACTH can be secreted by the ectopic secretions coming from the tumors conditions which we already talked about. ACTH independent causes, we have adrenal carcinoma or hyperplasia. One of the causes which is known here is McCune-Albright syndrome. Is a genetic disorders which affected, which we already talk about when we talk about thyroid. I already mentioned to you about McCune-Albright syndrome. Is a genetic disorders which affected the skin, the bones, and and it is multi-endocrine involvement. You can have the adrenal involvement, which can produce Cushing syndromes. You have the thyroid glands, which can produce hyperthyroidism. Just a recapitulate of this beautiful looking slide, which I took a snapshot from the book. Is endogenous Cushing syndromes divided into ACTH. This is endogenous, okay? Exogenous we already talked about. Endogenous Cushing syndromes divided into ACTH dependent, majority 80%, and ACTH independent causes, okay? So ACTH dependent causes are pituitary disease, the most common cause, ectopic secretions, and ectopic corticotrophin releasing hormones, okay? All right. So here we have ACTH independent. You have unilateral adrenal involvement. It can be adenoma or carcinoma, or bilateral is hyperplasia. When this hyperplasia is known as micronodular or macronodular. This is a macronodular, this is micro. This is known as primary pigmented nodular adrenocortical disease, or ACTH independent macronodular adrenal hyperplasia. Okay, these are known as these are just remember that bilateral, it is hyperplasia, which is micronodular hyperplasia, or macro or macronodular hyperplasia. Remove this thing which is given in the book here. This term now is obsolete actually. We don't use this anymore. So micronodular and macronodular hyperplasia, which are usually bilateral. Okay. So what are the clinical manifestations? The clinical manifestations of Cushing syndromes, I found that it will be easy to categorize as it can reproductive symptoms, manifestations, dermatologic, metabolic, cardiovascular, musculoskeletal, ophthalmic, neuropsychiatric, and infectious. Okay, let's go one by one. In reproductive, when reproductive mean what symptoms that the patients with Cushing syndromes will come? Usually, female patients usually comes to male patients. As far as reproductive is concerned, they do not have much of a problem, except that some patients may have decreased libido. Okay, you know that reproductive, you can have menstrual irregularities in females. The patient can have oligomenorrhea, amenorrhea, or even excess. Please put a comma here. Excess or variable menses. That means you just know that there can be menstrual irregularities because of excess. You know that. Female also have androgens, not androgen here, it should be androgens. So signs and symptoms of excess androgens. So androgens is a male hormones. Male hormone, the androgens is being secreted by the testis. As far as the female is concerned, the androgens come from the adrenal medulla. As you know that androgens is also important in females because it controls the secondary sexual characteristics. For example, like hair growth in the pubic area, axillary hair. Okay. So if you have excess androgens, that means this is excess androgens mostly is seen in patients who are having cancer of the tumorous conditions of the adrenal glands. So when you have tumorous conditions of the adrenal gland, there will be secretions of all the hormones of the adrenal glands. So ultimately, there will be excess androgens also. And these patients who are in women, there will be hyperhirsutism, increased hair growth, breast atrophy, clitoris enlargement, and masculine voice. Okay. Dermatologic, easy bruisability. That means because of loss of subcutaneous connective tissue due to the effect of steroids, the skin become thin. Okay, the skin become thin, and that is why it's known as they become easily bruised. So it is known as easy bruisability. Stripe. You know that a patient who is having Cushing syndromes, they present to you with excessive weight gain. And because of that weight gain, what will happen? And the skin is already thin, and in addition, there is weight gain, so the skin will be stretched because of the increased weight, and ultimately the stretch mark will appear, and these usually are purple in color. These are known as purple striae. Most common areas is the abdomen. Okay. The skin become atrophy, which I told you already. Then you can have infections of the skin. Infections of the skin are the most common one is the tinea bursicula in the trunk, and the nail infections. Hyperpigmentations, this is induced by increased ACTH secretions. A person who is taking cortisol, for example, will not have hyperpigmentations. Okay? But it is in those conditions where there is increased ACTH secretion. ACTH is the one that ACTH also stimulate the melanocyte stimulating hormones. So ultimately, this is the one that will produce a lot of melanocytes and will cause hyperpigmentation. So cortisol on its own do not cause hyperpigmentation. So it means you have hyperpigmentations in ACTH dependent causes of hypercortisolism. So the other is that you can also have pigmentations in the axillary area, which is known as acanthosis nigricans, which is axillary, and in the neck region. This is commonly seen in patients who are diabetic. Okay, metabolic, very important as far as metabolic is concerned. You know that it is one of the hormones that is counter-regulatory hormones that affect the blood sugar level. Here there will be glucose intolerance. I mean, the glucose will tend to be on the higher side. This is because of stimulation of gluconeogenesis and peripheral insulin resistance because of obesity. When the patient is having Cushing syndrome, there will be obesity, and because of obesity, there will be insulin resistance. And here, because of the increased secretions of cortisol, there will be increased blood sugar level, that is glucose intolerance. There will be progressive central obesity. The children with Cushing syndrome also have obesity and growth retardations. So you see, children, you have to mention about this. This is very important as far as your pediatric is concerned. Pediatric age group is concerned, that if the patient comes with growth retardation, suppose the parents bring the child to you and say that this patient is not growing up, but instead he is gaining a lot of weight and becomes so obese, you will have to consider Cushing syndrome. Patients of Cushing syndromes in children, they will come, one of the most important presentations that they have is growth retardations. Fat accumulations in the cheeks and in the temporal area, there will be fullness of the cheeks in the temporal area. This is known as the moon face. The buffalo hum, or the presence of fat in the dorso-cervical region, that means in the upper back and in the neck regions. So they'll appear huge, okay? And that is known as a buffalo hum. Enlarged fats that fill the supraclavicular fossa. Supraclavicular fossa, here you have, there will be lots of fats in that area. This is one of the most important presentations that you'll see in patients with Cushing syndromes. The patients with retroorbital fat deposition result in ophthalmos. Patient rarely fat accumulation in the epidural spaces can lead to neurological abnormalities. And patients with so much weight gain, they'll come to you with sleep apnea. Cardiovascular, very important. So Cushing syndrome, patients with Cushing syndrome have an increased risk of death from cardiovascular diseases, including myocardial infarction, stroke, and thromboembolic phenomena. Hypertension and dyslipidemia is very important. Then thromboembolic phenomena, the patient can come because of blood clots and because of changes in the clotting factors. Then there will be an increased chances of veno-thrombolic events. Okay, venous thrombolic thrombus formations. Ultimately, thromboembolic phenomena can happen. The other conditions that you can have in cardiovascular is rare. It can be heart failure or dilated cardiomyopathy. Bone or musculoskeletal, the patients with Cushing syndrome comes to you usually with proximal muscle wasting and weakness. And additions because of the changes in the electrolytes, which is hypokalemia, also will accentuate the will increase or accentuate the muscle weakness. There is excessive bone loss and leading to osteoporosis. And when you have osteoporosis, you will have backache, you'll have increased chances of fractures, body pain, okay? So these are the symptoms that usually have. Ophthalmic, you know that steroids is one of the causes of cataract and glaucoma. They will increase the pressure in the eyes, and that ultimately will lead to glaucoma and cataract. Neuropsychiatric patients usually comes with insomnia, depressions. At times you can have frank psychosis. You know, a patient who is having steroid psychosis, we call. So the patient become abnormal. The patient is put on steroids. For example, patients of tuberculosis, for some reasons, is being put together with steroids. Many a times they will come to you with psychosis. So sometimes you're confused whether, because one of the anti-tubercular drug also can cause psychosis, and that is INH, which is known as INH-induced psychosis. So steroids also can cause, then INH also can cause. So if the patient is not on steroids and on tubercular therapy, if they come to you with psychosis, most likely it is INH-induced psychosis. So however, just for your remembrance, I just mentioned here that a patient on steroids also can have psychosis. So that means in Cushing syndrome, there's a lot of steroids. They can come to you with depressions and psychosis. Impaired cognitions and short-term memory, emotional liability, irritability, anxiety, and panic attacks. Infections and immune system, like I mentioned previously, that glucocorticoids inhibit the immune functions, and because of that, they will increase frequency of infection. So now that you know about the clinical presentations, so what about the first slide which I show about it, the clinical presentations of the patients, you all remember about it. Okay, so these are clinical presentations. So little bit about why these, why the problems that we have. Okay, why there is so much obesity? They're because of lipid mobilization. The fat from some areas are being mobilized elsewhere. So, a patient who is having a Cushing syndrome, they will have a lot of fats in the central area, but they become very thin out in the other areas. That means the limbs will be thin. The fats from all the legs, lower limbs, upper limbs, and all will all be mobilized and go towards the upper back and the abdominal region. Lipid catabolism increases, that's why there will be dyslipidemia, then lipid redistributions, and because of the fat, this should be fat redistribution actually, fat redistribution, there will be moon face, buffalo hum, truncal obesity, and there will be stride, okay? And because of the effect on the liver, there will be the increased neoglucogenesis, so there will be hepatic glucose productions, and because of obesity, at the same time, there will be insulin resistance. And because of all that, because of the hepatic gluconeogenesis and the insulin resistance, it will lead to glucose intolerance. And why the patients will become fatigued? Why they become fatigued is because the muscles are weak. There will be protein metabolism, negative nitrogen. In protein metabolism, there will be negative nitrogen balance. Ultimately, there will be disruptions of the protein. The protein will be used up by the neoglucogenesis also, so the proteins will be removed from the muscles and the patients will become weak. Okay, there will be disruptions of water and electrolytes. Ultimately, there will be proximal muscle weakness. And because of this also, there will be edema, hypertension, hypokalemia, and metabolic alkalosis. So in short, we have about these. So again, the clinical features, let's talk about body fat, skin, CVS, reproductive, psychological, immunity, bone, and all this, which I have already mentioned to you, okay, about this, so we'll not proceed further. So little about here, you will see moon phases, you'll have dorsovesical fat accumulations, which we see here in the upper back and in the neck regions. This is known as buffalo hum. You have already seen a hum of buffalo. There is supraclavicular fullness, supraclavicular fossa fullness, which is a very important manifestation. There will be moon phase, truncal obesity. Okay, there are lots of fats in this one, and these stride. Okay, there will be stride and there are hyperpigmentations of the knuckles. Hyperpigmentations is seen in ectopic ACTH excess. So these are the stretch marks that you see. So, overview of diagnostic approach. How do we approach a patient with this? Okay, whenever you suspect a patient to have a patient coming with increased weight, increased blood pressure, and always ask whether they are on some drugs. It can be prescribed or it can be over the counter. It can be by the qualified healthcare personnel, or it can maybe by anyone, by the quacks. Okay, so you know that the steroids is one of the important constituents of many herbal medications. Okay, so you'll have to exclude not only the prescribed medications but also the patient which is bought over the counters or by the quacks. So who should be tested? When a patient comes to you with weight gain and all, exclude exogenous secretion. Always ask, not only the prescribed medications but other medications as well. So at the same, once you have excluded the exogenous corticosteroid as a possible cause of Cushing's, you have to think who should be tested. Who are the people whom you should think that they could be suffering from Cushing's syndrome? One is unusual findings for their age. For example, if a patient of 35 years, for example, come to you with osteoporosis, is not normal. A person who comes with a recent onset or young individual with new onset hypertension, not a normal thing. See, whenever I talk to you about, mention about hypertension, for the first time, if you have detected a person for the first time, again and again and repeated, is that you will have, when a person is detected to have hypertension for the first time, you will have to look for possible causes of secondary hypertension. For possible causes, one of them is this. Okay, so hypertension, whenever you detect it newly, especially in the young persons, you'll have to consider that it could be secondary, and one of the secondary causes of hypertension is Cushing's syndrome. Then, when you have patients who come with features of Cushing's syndrome like facial phletora, proximal myopathy, purple stripe, easy bruising. So if you have that symptoms, unexplained severe features like resistant hypertension. Suppose a person who is having hypertension, but not controlled by the usual medications, which you'll have to add more than 3. That is, when you add more than 3 drugs, and one of them is a diuretic, and if that person's high blood pressure is not controlled, then it is known as resistant hypertension. So resistant hypertension means that a patient is already on more than 3 drugs, and one of them should be a diuretic. And in spite of that, if the blood pressure is not controlled, that is known as resistant hypertension. Okay, so adrenal incidentallomas. For example, if a person who comes to you with adrenal incidentalloma, for example, you do for some reason, it could be a renal stone, or it can be cholelithiasis, a patient is being evaluated for that by ultrasound and detected, or CT scan for some reason for the stone, for example, and they found that the tumor is there in the adrenal gland. Those are known as incidentallomas. So incidentallomas mean we call about incidental finding. If you have incidental finding of a tumor in the adrenal gland, that is known as adrenal incidentalloma. So if you have an if you detect a tumor in the adrenal gland with or without symptoms, you have to work out to rule out Cushing syndrome. Okay, how do we diagnose? How do we approach a patient with Cushing syndrome? Is that number one is if the patient present to us with signs and symptoms of Cushing syndrome. So the first thing is it really that the patient is having Cushing syndrome? So that we establish whether what you thought of or what you think of or what the patient presented with, is it really Cushing? So I mean, you have to establish whether it is true, whether it is really that the patient is having Cushing syndrome. Suppose yes, what are the tests you'll have to establish the cause of Cushing syndrome? So you know that we have already divided the causes of Cushing syndrome into ACTH dependent and ACTH independent. So one of them is that if you want to know whether the cause of Cushing syndrome, so you establish the cause of Cushing syndrome means you will have to do some tests which will confirm that there is increased cortisol secretion. So you can do a serum cortisol, for example, or a urinary free cortisol. If that is high, then you will have to go for ACTH is ACTH estimation. If ACTH is high, then that is ACTH dependent. If ACTH is low, then it is ACTH, or ACTH is normal or low, then it is ACTH independent. Then if ACTH is high, then you have to also find out the source of ACTH. Is it from the hypothalamus, or is it because of the pituitary, or is it because of ectopic? And how you do this is because of imaging studies. So now we go. Let's go to the first one, which is establish the diagnosis of Cushing syndrome. How do we establish the causes or diagnosis of Cushing syndrome? Cushing syndrome in hypercortisolism. So you have to prove, number one, that the patient is having increased cortisol secretion. So what tests do we do? One is you do what is known as 24 hours urinary free cortisol. The number two test is low dose dexamethasone suppression test. The third test is the midnight plasma cortisol or late night salivary cortisol. I'll go one by one and extract you about this. Okay. So these are the tests to establish the diagnosis of Cushing syndrome. So one is 24 hours urinary free cortisol. So direct assessment of circulating free cortisol. Urinary free cortisol usually direct the assessment of circulating free cortisol. Cortisol are in the body is of two types. One is the free and one is binded. It is binded with the cortisol binding globulin. So that cortisol binding globulin will not be secreted into the urine. So what you estimate is the free cortisol. Okay. So you have to do two collections of 24 hours urinary collections. If the 24 hours urinary free cortisol is more than 3 times the upper limit of normal, then you know that this patient is suffering from Cushing syndrome. That means the cortisol in the body is high. Are you there?
Yes, sir. Yes, sir. Yes, sir.
Do you understand?
Bit.
Do you have any problem in understanding this?
No, sir. This one is okay.
It's clear, right?
Yes, yes, sir. Yes, sir.
Okay, so I hope you understand. So cortisol in the body are of two forms. One is the binding form. Another one is the one which is free. So we talk about the cortisol which is bounded to the cortisol binding globulin. So you know that protein is not normally secreted in the urine, right? Not all urine. So globulins, not all proteins, except a very small amount, which are very low molecular weight, okay, will be excreted. Otherwise, you will have excess protein only when there you have a disease of the kidney, okay, like nephrotic syndrome, for example. Okay? So that is why we don't estimate the binding globulin. We don't estimate the binding cortisol in the urine because it's pointless. So we have to estimate the free cortisol. The free cortisol means it circulates and it is filtered by the urine, so it will go. So you have to take two collections. You know, when I talk about diabetes, I said that increased blood sugar level on 2 separate occasions. Here also, whenever we talk about increased blood pressure, for example, we don't take only one collection. We decide to call the patient again. Same thing here. Just because of an increased cortisol secretion one time doesn't mean that the patient is having Cushing's. You have to estimate at least 2 times. And when you estimate the urinary free cortisol, when do we say abnormal? When it is more than 3 times, 3 times the upper limit of normal, then that is known as that the patient could be suffering from Cushing syndrome. Next is what is known as the dexamethasone suppression test. Dexamethasone suppression test. We have here, there are 2 types of dexamethasone. There are 2 types of dexamethasone suppression test. One is the low dose and the other one is the high dose. The low dose we use 1 milligram of dexamethasone and the high dose is 8 milligram. So make this properly. Just note this point, very, very important for you, that for the diagnosis of Cushing syndromes, I'm repeating, for the diagnosis of Cushing syndromes, only low-dose dexamethasone test is used. Okay, for the diagnosis of Cushing syndrome, only low-dose dexamethasone suppression test is used. However, the high-dose dexamethasone test is used to find out the cause of the increased cortisol, but not for the diagnosis. Okay, so let's go to this. What do we do the low-dose dexamethasone test? You know, I already mentioned to you that the steroid secretions from the body or the hormone secretion from the body depends on the feedback mechanism, right? So what happens if you give what secretes the cortisol from the adrenal gland? It is because of the release of the corticotrophin releasing hormone from the hypothalamus. That corticotrophin releasing hormone will stimulate the anterior pituitaries to secrete the ACTH, and the ACTH will stimulate the adrenal gland to secrete the cortisol here. So what happened here, if suppose you give steroids from outside, in the normal conditions, 1 milligram of dexamethasone is a very good amount of dose. So if you give 1 milligram of dexamethasone, what will happen is that the serum, the steroids, the corticosteroids in the body, in the blood will increase. When it increases, what will happen? What negative feedback will go to the hypothalamus? The hypothalamus will be suppressed. So here, anyway, a little bit before that, let me talk to you that the diurnal variations of secretions of cortisol. Cortisol secretions is maximum in the morning, 8 a.m., 6 to 8 a.m., and it is least in the evening, okay? In the evening. So that is the reason we give here administrations of 1 milligram of dexamethasone at around 11 p.m. to 12 midnight, and you measure the serum cortisol at 8 a.m. the next morning. So what happened when you give 1 milligram of dexamethasone at night? There will be an increased level of glucocorticoids in the blood. Agree or not? Can you hear me?
Yes, sir.
So when you give from outside, will they increase glucocorticoids in the serum? Suppose you give insulin. When you give insulin, what will happen? Will the sugar drop or not?
Yes, sir.
Yes, that means the insulin increases in the blood, right? That's why it will reduce the blood sugar. Agree?
Yes, sir.
Right?
Yes, sir. Yeah.
So here, when we give, suppose let's forget about hormones. Suppose I give the ceftriaxone to our patients. Will the ceftriaxone go to the blood or not?
Yes, sir.
Yes. So that means it will attain a therapeutic level and it will kill the organism. So that means it will act as an antibiotic, right? So here again, if I give dexamethasone from outside, the level of corticosteroids in the glucocorticoids in the blood also increases. It will be there. So if the dexamethasone is already there in the blood, the glucocorticoids are already there in the blood, what will happen? Now the hypothalamus say, I don't need to secrete CRM, that means the corticosteroids releasing hormones. So what will happen? That means the hypothalamus will be suppressed. Okay? So if the hypothalamus is suppressed, what will happen? Will the ACTH be produced?
No.
If suppose the hypothalamus do not secrete ACTH releasing hormone, will the pituitary secrete ACTH?
No, sir.
No. You see, when you have a level which is already adequate for the body, the negative feedback will go to the hypothalamus. I'll say I will not secrete because the level of steroids is already adequate for the person's requirement. So what will happen here? You measure the serum cortisol at 8 a.m. the next morning. You will find that the serum cortisol is low. That means it is not stimulated. That means what will happen? That means the suppressions of the hypothalamus by the exogenous dose is adequate. Okay, that means because of the dexamethasone which you give at night, that means that dexamethasone suppresses the hypothalamus to secrete the corticotrophin releasing hormone. So because of the hypothalamus not secreting the corticotrophin releasing hormone, the ACTH from the pituitary will not be produced, and ultimately if the ACTH from the pituitary is not produced, then the steroids from the adrenal gland is not produced, and that is why when you estimate the cortisol in the morning, the cortisol level will be low. Got the point?
Yes, sir.
So that is known as a low dose dexamethasone suppression test. So the diagnostic criteria is that when the steroids is less than 50, which is considered as 50, then it rules out Cushing's. I mean, it is adequately suppressed. That means the body, when you give steroids from outside, the body responds and it does not secrete. That means the cortisol level is low. That means it is adequately suppressed. When it is adequately suppressed, means the normal mechanisms are intact. When the normal mechanisms are intact, that means the patient is not suffering from any disease, and that will rule out that the patient is having Cushing syndrome. Okay, so one is the overnight, the other is the standard 2-day milligram test. This is a low dose again, where this is not usually used. Okay, so what the standard 2 days milligram test is done is that you give the dexamethasone instead of giving at night. You give in divided doses, small amount, 0.5 milligram of dexamethasone every 6 hours for 8 doses. Measurement of serum cortisol either 2 or 6 hours after the last dose. So this is the standard low dose dexamethasone suppression test. However, the most common one is the overnight 1 milligram dexamethasone suppression test. So you give dexamethasone at night, and if you calculate the cortisol in the morning, it is low, you know that the patient is not having Cushing syndrome. That means, as the name suggests, dexamethasone suppression test. What it is supposed to suppress? It is to suppress cortisol secretion. But if the cortisol secretion is low, that means it is adequately suppressed. So when it is adequately suppressed, it is not Cushing. Because in Cushing syndrome, if the patient is having a disease, irrespective whether you give dexamethasone or you do, the cortisol level will remain. So the next one is we already talked here that you go for the midnight plasma cortisol. One is the 24 hours urinary free cortisol, the low dose dexamethasone suppression tests. We will talk about this dexamethasone suppression test again if we meet physically in the class, okay?
Yes, sir.
The other one is the midnight plasma cortisol or late night salivary cortisol. Just now I told you that the diurnal secretions of cortisol is that it is maximum in the morning and it is minimum in the evening, and the most important one is the midnight. You know that it is late in the night. So we expect that the plasma cortisol will be low at night. So if you do an estimation of plasma cortisol and it is less at night, so that means the patient is not having any disease. So that means the patient is not having Cushing syndrome. That means you rule out the diagnosis. But if you do a midnight plasma cortisol, it is high. It is more than 207 as the cutoff point. Then that means this patient is having a very high steroid, because normally at midnight, the serum cortisol should be less than 50. But if you have a level which is more than 207 nanomole per liter at night, when normally it is supposed to be less than 50. So that what do you mean? What does it mean? It means that the patient has a very high cortisol secretions. Even when you took the level at the point where it is supposed to be the least, the cortisol secretion is supposed to be maximum in the morning and is supposed to be least in the night, in the midnight. So at the point when you take the level at the point where it is supposed to be least and still it is high, that means it rules out in favor of Cushing syndrome. That means without doing any suppression test, without doing anything, you know that this patient is likely that the patient is having Cushing syndrome. The other test is the late night salivary free cortisol. Suppose you have a problems. You have a problems where the patient cannot draw the blood samples at night. What will happen? So these patients actually, they are given, they usually, we take the salivary secretions, okay? Because the cortisol also can be estimated from the saliva. So this patient will collect the saliva by chewing on a cotton, okay? And this cotton will be given to the, will be brought for the estimation of cortisol, and that also will be high or will be low. If it is low, that means it is normal. If it is high, that means it is in favor of Cushing syndrome. So late night salivary free cortisol, not exactly done because these patients, this is also usually not done because the morning sample is adequate and the urinary free cortisol is adequate for the diagnosis. However, this you have to know that what are the tests is done, what are the tests that is done for the diagnosis of Cushing syndrome. So here to recapitulate here, for the diagnosis of Cushing syndrome, so we have to find out the level of cortisol level. What test will tell us that the patient could be having syndrome is the high cortisol secretions. So if you have high level of cortisol, that means the patient could be having Cushing syndrome. So what are the tests that we do to estimate the cortisol in the body? Is 24 hours urinary free cortisol, low dose dexamethasone suppression test, the midnight plasma cortisol or the late night salivary cortisol estimations. So these are the tests for the diagnosis of